right, guys, we'll be coming on in to kind of further our presentation. All right, guys. So here we are with our OEC 9900. This is our C-arm that we use on a regular basis. More than likely, 9 times out of 10, you're going to see an OEC. Well, maybe that's too high. 8 times out of 10, you're going to see an OEC machine in the room. Here's our table that we kind of went over with. So we would have a patient come in. They would lie on the table, head up top here, and then we add patient information. And so we would go here, and then we would add last name, first name, date of birth. If the patient does have an ID number, we would fill that in. Of course, you'd want to know which physician is doing the procedure, and then any comments down here, and the procedure's name as well. And then we would swing in here. Now for our procedure, which is this snurb, that is cervical snurb, I should say. That's a procedure where we're looking at cervical, the patient's neck, and trying to relieve pain that's going down from neck to hand. And so for that procedure, you have a patient lying straight up like so, which is the PA position. So you would have the patient lying up, faced up, and then you want to line up your C-arm above the patient. And then from there, let's see if I can do this for you. And then so from there, let's say the anatomy that we're focused on is on the left side of the patient. So that would be closest to us with the patient face up. And so your physician is going to ask for a steep oblique. And so you would want to go towards the side of the anatomy, not contralateral, towards the side of the anatomy that you're looking at. So we would give it a steep oblique. Some physicians like about 50 degrees, some 35. It just depends on who you're working with, of course. But we would give that oblique, and then the insertion of the needle comes. From there, you have the insertion of the needle on the left side, which would be the trajectory point for the C-arm and the needle, where we're trying to land. And then your physician's going to ask you to go AP to watch contrasts travel down the nerve route on down to relieve that pain. And so we would swing it back to a PA position, PA posterior to anterior. Posterior is the source of the x-ray is down here. So we're coming from the source through the source to the II, and in anatomy purposes, that would be posterior from the patient through to anterior from the patient. So that's what we call PA position. And then from there, you're kind of sitting like this, waiting for the physician to finish up the contrast dye, and then placing the steroid injection or the medicine, if you will. But that would be a snurb. And from there, we can transition to something in the lumbar spine. So as easily as just kind of pulling the machine over down this way. You always want to watch at the bottom here because you can bump into things. So we always play with the table a little bit. As RTs, we play with the table and the machine a little bit. But then you're going to kind of line up for anything that's lumbar spine. It'd be down here towards the foot of the table. Key things with lumbar spine is end plates. It's kind of with everything, but an end plate, you want that lined up to have the image as optimal as possible for the physician to get the job done. And so there's certain things in the anatomy that you'd want to know. Scotty dogs, as we know, lumbar spine, facet joints. There's so much anatomy that you need to kind of brush up on and make sure you know when you step into a pain management room. Yeah, for sure. We want to thank you guys for coming out and supporting Ascension Medical Staffing in our first seminar. We appreciate all the faces that came out and supported today. Thank you guys.